Hello dear mamas, today as I promised I will be talking about endometriosis, which is disease that I have. So we will talk about all my process and a few questions that you sent me through the Instagram account. And Dr. Erin, please talk about what you do, where you work.
My name is Dr Erin Nesbitt-Hawes and I work both here in my private practice at Alana Healthcare for Women, as well as over at the Royal Hospital for Women where I met you. My area of interest in gynaecology is in endometriosis and women who have pelvic pain. I focused on this area throughout my training. I did an advanced laparoscopic fellowship so that I had the skills needed in order to effectively treat women with any stage of endometriosis. And one of the other hats that I wear is on the medical advisory board for Endometriosis Australia, which is a not-for-profit group in Australia which also looks at trying to educate and create a forum of support for women with endometriosis.
That's amazing. I didn't even know that. Okay, we are back with Dr. Erin. So just to clarify about me, I've done a laparoscopy last year, in May last year, and my doctor have never done a laparoscopy in Brazil, but he had at the time diagnosed me with like ultrasounds and touch and say, look, just use your IUD to prevent you getting your period and then you'll be fine, which actually helped with the pain, but eventually I started to feel the pains even with the IUD again. So then that's when I went to the hospital and I needed to get the procedure done. So my first question comes along exactly like that, because you guys ask, what is endometriosis and what causes it?
Yeah, so endometriosis is a condition that affects 10% of women, or 1 in 10 women, and it's where cells that line the inside of the uterus, so the endometrial cells very similar to those are present outside of the uterus. And they can be anywhere, most commonly in the abdominal cavity and around the pelvic organs, so maybe underneath the ovaries or on the ovaries themselves. They can implant on the surface of the bowel or the bladder, and they can even go to more distant locations, so sometimes on the diaphragm or the breathing muscle, sometimes in the lungs, and in very rare circumstances there have been case reports of endometriosis even in brain tissue.
Wow.
So it's a bit of an enigmatic disease that we don't have a full answer as to why it happens, but we're doing a lot of research to try and work out what those factors are, and certainly there seems to be a genetic component of endometriosis.
Right.
And for some women, endometriosis runs in families, or pelvic pain issues can be present in mothers and grandmothers or aunts, and this is something that we're finding more and more, that there are genes identified which have an association with endometriosis, but it's not an easy thing to diagnose because it's multiple genes and they probably have different impacts, and in any individual woman it's a combination of those genetic factors and possibly some environmental factors, although again we're not really sure what those are to trigger the genes to turn on or off. And what results is this condition where these endometrial cell deposits are present where they shouldn't be. We suspect that there's an immune association in women with endometriosis, where in a normal woman without endometriosis, the immune system might be able to get rid of or clean up those cells. And one hypothesis is that those cells have actually come from blood that's spilled through the tubes and into our pelvic cavity, which is a normal thing that happens for almost every woman during her period cycle, but not every woman gets endometriosis. And we think part of the reason for that is that the immune system in women with endometriosis isn't capable of mopping up those cells, and if they implant and if they attach, then what happens is that the body's response is an inflammatory response, and it's the inflammation around those areas that tends to go on and causes one of the biggest symptoms for women, which is pain.
Yes, pain. Yes. So I also found out, and I didn't know about it, there was 3 types of endometriosis. Would you talk about the difference of them and whether they have different symptoms as well?
And how we qualify endometriosis is according to stages. And there are actually 4 stages of endometriosis. And the criteria for determining that is really, it's a surgical criteria. So it's what we see at the time of the laparoscopy, how much endometriosis tissue is present, how deep it is invading or infiltrating into the tissues, whether there's any endometriosis present on ovaries and causing ovarian cysts, which are called endometriomas, or whether or not there's a whole lot of adhesions and the endometriosis is actually sticking all of the internal organs together.
Ooh.
And stage 1 is the least amount of endometriosis. Stage 4 is the most amount of endometriosis. But the difficult thing around endometriosis is that those stages don't actually correlate with symptoms. Neither pain symptoms nor fertility symptoms. So we can have a patient with stage 1 endometriosis who has very severe pain, and we can have a stage 4 patient with endometriosis who may have not realised she had endometriosis and it was picked up during either an ultrasound investigation or an operation for something else, and when we discover it. The stages of endometriosis are more relating to the surgical difficulty in removing that endometriosis and the organs that are affected, rather than giving us information about what that woman is experiencing.
I think it was a TED talk that I've seen about endometriosis where they were calling it as the iceberg disease, that even when you are doing the procedure, the laparoscopy, you still can only find so much.
Yeah, absolutely. And look, I think where that comes into play is the fact that on the surface of the tissues, we may see a relatively smaller amount of endometriosis, but it's only really as we're excising or removing that area of endometriosis that we get a full idea of how deep the tissue is infiltrated, how much is involved. And sometimes we do find that if you just looked, you would say, oh, there's a little surface area of endometriosis, but when we go to remove it, it's a bigger amount of endometriosis. That's one of the reasons why some gynecologists recommend that we do excision surgery for endometriosis, because the aim of that is actually to remove all of the affected tissue to try and get all of the endometriosis out, as opposed to ablation surgery, which is where we burn the surface of the lesion that we can see, but don't necessarily pull out the larger aspects of the disease. And both can be effective in the treatment of endometriosis, but for certain pain types, like deep pain with sex, for example, that's something that we think excisional surgery, where we're removing a deeper nodule of endometriosis, is probably more effective than just burning the surface.
How should a woman, since it's so difficult to diagnose, and having the 4 stages, some people feel pain, some people feel no pain at all. Yeah. How would they suspect they have endometriosis? What are the minimum symptoms that you can have to go, and how you get even tested for it?
So the main symptoms that women have with endometriosis fall under 2 big categories, and that's pain symptoms and fertility symptoms. Period pain is one of the most common symptoms that women with endometriosis have, but you don't need to have period pain to still have endometriosis. So I would
the pain doesn't necessarily come with the period
No,
sometimes.
correct, exactly. So pain can come either with the period, sometimes it can come in between periods, and that's what we call non-menstrual pelvic pain. It can occur at any time of the cycle. Women might be getting pain with going to the toilet to either empty their bladder or their bowels, and having pain with sex is quite a common symptom as well. The criteria for looking into or trying to diagnose or work out what's going on with endometriosis, from my perspective, is where we're having pain which is really interfering with women's capacity to live a normal life. So whether that be you needing to take time off every single cycle with your period, whether you're not able to have a normal sex life because pain with sex is so bad, any of those sorts of issues where they're, you know, becoming a really something that's impacting on a woman's life. Those are the things that where we would want that woman to initially start off by going to a GP to raise the concerns, but then usually being referred to someone like myself where we can investigate further what's going on and what might be the cause, and certainly looking at endometriosis. It's normal then for us to examine the woman, and the pelvic floor and the pelvic floor muscles are often part of the problem in association with endometriosis, and often muscles are really tight and over-contracted, and they can cause their own sort of pain. But we're also examining internally to see whether we can actually feel any endometriosis, whether we can feel any of the endometriosis cysts. And
this is an ultrasound, or is
that's an internal examination that the gynaecologist will do, but usually then, yes, we refer for a pelvic ultrasound. And in a lot of cases with endometriosis, the pelvic ultrasound is going to be completely normal.
Wow.
Which is a shame, because it's a imaging modality that we would hope could diagnose the disease, but it can't diagnose all forms of endometriosis, especially when we're talking about stage 1 and 2 disease, which is often small volume disease and much more difficult to pick up. What ultrasound can tell us more about is the higher stages of disease. So when women have stage 3 or stage 4 endometriosis, and that might include endometriosis cysts, the ovaries might be a bit stuck to the pelvis or to the uterus, the bowel might be stuck to the uterus. So a good quality ultrasound, often at a specialist gynecological ultrasound department, will be able to diagnose endometriosis.
Or at least some indirect.
Yes, it'll give us an indication. So for some women, we can have a fairly confident diagnosis even before we go to a laparoscopy. But as you mentioned before, a laparoscopy is what we call our gold standard for diagnosis, because it lets us see what's happening on the inside. It lets us remove any areas of endometriosis and send those off to pathology, and then it's the pathologist who looks at those tissue under the microscope that gives us the definitive diagnosis of, yes, this is endometriosis. And up to that point, we're working on a clinical suspicion of endometriosis. We do treat women, you know, for endometriosis without necessarily needing to proceed initially to a laparoscopy. That's my next question.
Yeah. So if you don't think that it's in a specific case for any reason, they don't need to do the laparoscopy, or they don't want to, what would be the alternative treatment? Using
hormonal treatment. So one of the biggest areas of treatment in terms of endometriosis, and that could include the oral contraceptive pill, it could include progesterone only pills. There's some specific progesterone pills marketed for treatment of endometriosis. There are long-acting progesterone devices like the IUDs or the rods, and so all of those hormonal treatments are possible treatments for endometriosis, and endometriosis unfortunately is something that we can't cure. It's a condition that once you're diagnosed with it, you have endometriosis. Exactly. And it's managing the symptoms of endometriosis, which is the most important thing. Endometriosis won't kill you, but it does cause significant discomfort and fertility issues, and so what we're trying to do is manage endometriosis. And if we can manage endometriosis with hormonal treatments, that usually is our first step. What your doctor did in Brazil would be a similar thing actually to what I would have said would be my first step here. Unfortunately, a lot of women are in the same circumstance where that may work for many years, and eventually they start to get pain again.
And regardless of having a period or not.
Regardless of having a period or not. And the hormonal treatments work to help with symptom management. They also do help to slow the progression of endometriosis, and that can be helpful as well in terms of our overall treatment of the disease. But for a lot of women, eventually pain symptoms may reoccur, and in that circumstance we sometimes look at alternative hormone treatments, but also we look at whether surgery might be required.
Right. I came to put my name for the surgery, and at the same time I removed my IUD because I wanted to start trying to conceive. In my case, I wanted to see which one would come faster, the surgery or the baby. The surgery came faster than the baby. And some people, so there are two questions. One, the first question is if effect on fertility.
Yes.
And the second question is, some people told me that if I had a baby, after the baby I wouldn't feel the struggles of endometriosis anymore naturally.
Yes.
Is this true?
Yeah.
Both? Yeah.
Yes, absolutely. So endometriosis can definitely affect your fertility, but the likelihood of it doing that is only there for about 1/3 of women. So 2/3 of women with endometriosis have no problems conceiving, which is great. That's the majority of women. We usually do recommend that we try naturally to conceive, and a lot of women are going to be able to. If conception hasn't occurred within a 12-month time frame, or...
Is it different if you are over 35, the time?
Look, we usually have a slightly tighter time frame because obviously time is ticking a little bit. So, we might reevaluate at 6 months for women who are a little bit older. But if nothing's happened in that period of time, or if once we stop the hormonal treatment, the pain is becoming significantly worse, because that's obviously one of the risks when we have to be off it to try and achieve a pregnancy. Exactly. If the pain is so unbearable, then a laparoscopy is indicated. And we know that in the circumstances where endometriosis is affecting fertility, removing that endometriosis improves that woman's fertility back to more like what her baseline level is for her age. And that's a benefit that we see for stage 1 and 2 endometriosis, but also a benefit that exists for stage 3 and 4 endometriosis as well. We think that it's because it decreases the local inflammatory factors within the pelvis by removing that abnormal tissue. That creates a better environment for the egg to be released, for sperm to get to the egg, for the embryo to then get to the uterus and implant.
A big clean out.
Exactly, basically.
Is that a myth that if someone gets pregnant?
Your other question. So unfortunately, it is a bit of a myth. Look, there are patients who find that Yes, their symptoms do improve after pregnancy, and it's fantastic when that happens. It's hard to know, again, why. I would say the majority of my patients with endometriosis, unfortunately, start to get pain symptoms again, even after having a baby. So an old-fashioned cure for endometriosis was to go and get pregnant and try and have a baby. Hormonally, everything is very suppressed during pregnancy, so often pain is actually a little bit better, and obviously you're not getting periods, so that's a good thing. And pregnancy is a time where a lot of my patients are like, this is going really well. But once your periods start to return again, maybe after you've stopped breastfeeding, that's when sometimes we see that pain symptoms may reoccur, and that's where we might again use some hormonal treatment to try and control the symptoms.
If you're trying to have, a natural conceiving naturally, and you don't want to have sex, that kind of makes it all difficult, even if you don't have necessarily the infertility issue.
Absolutely.
But then you don't want to have sex, so it's kind of a bit difficult.
Yes, exactly. One thing leads to the next.
Exactly. If someone is watching this video now and they suspect they have endometriosis, what would they have to do first thing? Which kind of doctor would they need to see? And
the first step is always to see your family doctor or your general practitioner, who will be able to often organise some of the initial baseline tests, maybe a pelvic ultrasound, and to refer you on to someone who has an area of specialisation, in pelvic pain or endometriosis, who is local to you. Information about those gynecologists, is obviously hard to work out who's the right person to go to, but support groups like Endometriosis Australia, like EndoActive, there's a lot of different statewide support groups as well, can be helpful to get information about who to see, and there's information as well on the AGES website, so that's the Australian Gynaecological Endoscopy Society, so it's a society of people like me where we practice advanced laparoscopic surgery, and most of us will do endometriosis surgery, so finding the right gynecologist to go to, I think, is important, because they're going to be able to give you the range of options in terms of treatment. And I should say that although hormonal treatment and surgical treatment are the mainstays for treating the actual disease, there's often a lot of other things going on that we help in a kind of multimodal approach. So things like pelvic floor physio if your muscles are really contracted, things like nutrition and dietetics if you've got a lot of bowel related symptoms, because sometimes some dietary changes can help to minimise symptoms such as bloating. We find that pain psychology can be really helpful to give you strategies to help cope with the pain when it's there. Exercise has been shown to be a useful way to help to control some of the pain. Look, a lot of types of exercise can be helpful, but a lot of my patients find that they're limited in terms of what exercise they can perform because maybe they get pain. And there's been lots of research into things like yoga and Pilates and the importance of those types of exercise. And I think they give you a combination of things. There's good muscle stretch and relaxation and strengthening of the right muscles, but I think there's also the meditative effect within those types of exercise, which has also shown to be really helpful. Even acupuncture has been shown to be useful for period pain and pain related to endometriosis. So there's lots of different things that we can also try, not just surgery and hormonal treatment, because for some women they can't use hormonal treatments or they get too many side effects, or so there's various reasons, and it's really important to find the right doctor who's going to be able to tailor all of those treatments to you.
Last question is about the laparoscopy itself, because for me it was actually a bit of a surprise. I thought by the end of the day I would be going home and it wasn't the case for me, and I was throwing up after the surgery. I had to stay there one night, and the recovery time for me was about 2 weeks, really, because I had a lot of pain on my neck and shoulders. And I had a meeting the next day, so don't book meetings the next day. Don't be so optimistic. What does it happen in a theatre or in a surgery room?
So the surgery is done under a general anaesthetic. If you don't feel anything, you're not aware of anything that's going on, and you wake up afterwards in recovery, what we do is we put a telescope in, usually through the belly button, and a couple of other little ports around the bottom of your tummy, and everyone's a little bit different as to where we place those ports. When we're doing that surgery, what we're doing is we're looking at all of the organs and the areas around the ovaries and uterus. We're trying to identify any endometriosis. We use gas, carbon dioxide gas, to inflate the tummy. So if you have a look from the side, everyone looks a little bit pregnant because the tummy's really stretched out, and that helps us to see what's going on. It separates all of the organs, but it's part of what contributes to one of the symptoms that you had after the surgery, which is really bad shoulder and neck pain. And that's because no matter how hard we try to get rid of all of that gas at the end of the surgery, there's always an element of gas trapping. And it usually goes underneath your breathing muscles, up here under your diaphragm, and the nerve sensations to your diaphragm is the same as the one for your shoulder. So it's a referred pain. Nothing's actually happened to your shoulders usually, but you have that sensation of a really big shoulder workout or a lot of muscular pain, and that can be one of the most annoying symptoms actually after having the surgery. Women may be asked to stay overnight, or they may go home on the same day, and it depends a little bit on how much endometriosis we remove and what the pain is like after the surgery. I would say the majority of my patients probably stay for an overnight stay, so it would be more common to stay overnight than to not. And we want to make sure that there's adequate pain relief and anti-vomiting medication and all of that sort of stuff for after the surgery. And then it would be fairly normal for about a week after the surgery to still be feeling some pain for the surgeries, to still be needing some pain relief. The whole recovery period in an internal sense takes about 6 to 8 weeks.
Wow.
So it's not uncommon to have the first few periods after the surgery to be a little bit more painful or as painful as they were before, because everything inside is a little bit irritated. And once that lining of the abdominal wall, the peritoneum, has grown back over after the surgery, that's when we see the biggest improvement from a pain perspective.
Wow. So good. Thank you so much for participating.
You're welcome.
Interview.
No problem.
Tell anyone that is in Sydney, Dr. Erin here in Sydney, that wants to see you.
Yes.
Where would they find you?
So I operate out of 2 practices. So Alana Healthcare for Women is my private practice. You can find it online. I'm sure Cindy can put up the link. That's in a private setting, but you can also see me through the public hospitals. So I have a gynecology clinic up at the Royal Hospital for Women as well, and you'll be seen by either me or one of my group of doctors up there. It's no different in the public or the private setting.
Just the waiting.
Just the waiting, yep. The waiting list is different.
Thank you so much. Very kind of you to take this.
No problems at all.
You're welcome.
You're welcome. It's always important for everyone to know about endometriosis because it's an under-recognised and under-diagnosed disease. March is Endometriosis Awareness Month. So
it was a coincidence.
Well, everyone get out there and support endometriosis, and there's lots of women in the same situation, so don't feel like you're alone in this.
No, we are here to help each other.
Absolutely. Absolutely.
Thank you so much.
Okay.
And I will see you in the next vlog. Bye-bye.
Bye.